My name is Dr. Louis Cohen. I'm an assistant professor at the Icahn School of Medicine, and I'm here to talk to you today about our recently published manuscript in Gut entitled Reparative Immunological Consequences of Stem Cell Transplantation as a Cellular Therapy for Refractory Crohn's Disease. What is already known? We know that despite advances in therapeutic development, there are a large number of patients with Crohn's disease that remain refractory to therapy. Patients with medically and surgically refractory Crohn's are at risk for bowel failure, leading to increased morbidity and mortality, as seen here. Multiple studies have demonstrated that autologous stem cell transplant can be effective in patients with medically and surgically refractory Crohn's. In stem cell transplant, stem cells are mobilized from the bone marrow, in our case using cyclophosphamide and G-CSF. They are then frozen, after which patients are given conditioning chemotherapy with anti-thymocyte globulin and cyclophosphamide, followed by transplantation of the stem cells. Despite the efficacy of stem cell transplant for Crohn's disease, little is known about how haematopoietic stem cells may drive immune reconstitution and reverse the pathophysiology of Crohn's disease. We found that stem cell transplant leads to clinical improvement in the majority of patients, as measured here by the Harvey-Bradshaw Index and the Crohn's Disease Activity Index at 6 months post-stem cell transplant. We also observed that stem cell transplant leads to endoscopic improvement in the majority of patients, as measured by the SES-CD score, with an endoscopic response in 92.86% of our patients. When we looked at immune reconstitution events in both the blood and the intestine using mass cytometry, we found that very similar to observations in cancer patients, stem cell transplant largely affected a small number of lymphoid populations in the blood post-transplant. When we looked at the global changes in the immune system in the blood, we did not see great differences in our patients pre or post-transplant, as seen here with this principal component analysis. In contrast, analysis of the intestine revealed a very distinct effect of stem cell transplant on different populations, especially among myeloid populations, including CD14 cells and neutrophils. And in fact, the differences in the global immune makeup of our patients in the intestine post-transplant was distinct at 6 months post-transplant. These studies supported that looking at just the immune reconstitution event in the blood is insufficient to predict what's happening in the intestine in our patients with Crohn's disease. When we looked at these immune reconstitution events, again using a VCNE analysis, we really saw profound remodeling of both neutrophils and CD14 cells, as seen here, where it appeared to be almost a complete reconstitution of this immune lineage, suggesting that in the intestine at least, the most profound changes we saw were for reconstitution of the myeloid lineage, especially CD14 cells. We then used single-cell sequencing to understand what are the functional consequences of these changes in the intestinal immune system post-transplant. And what we saw were profound changes in how specific, what we call hub clusters, including LYVE1 macrophages, glial cells, and stromal cells, interact with epithelial clusters post-transplant, with an increase in interacting pairs, again, between these hub clusters and epithelial enterocytes, as well as BES4 stem cells, suggesting that stem cell transplant restores epithelial interaction networks involving macrophages post-transplant. When looking at how macrophages again remodeled post-transplant using single-cell sequencing, we saw that at baseline, inflammatory monocyte and macrophage populations may be impairing epithelial healing, whereas these populations change post-transplant to homeostatic functions that support epithelial healing through a variety of growth factors, including IGF-1. This further suggests that stem cell transplant may restore intestinal macrophage populations that support epithelial healing. When we looked at the stem cell graft, we saw a bias towards myeloid progenitor populations compared to lymphoid progenitor populations, suggesting that the graft may actually be driving this myeloid reconstitution events that we're seeing in our intestine post-transplant. We then looked at the function of the stem cells and their ability to engraft and differentiate in a xenograft mouse model, and we found first that there was tremendous variability of stem cell engraftment from Crohn's patients, which was atypical compared to historical studies of healthy patients. and that this variability in stem cell engraftment and function may correlate with transplant outcomes, with poor stem cell functions leading to incomplete response to transplant and early disease relapse. So how does this affect our clinical practice? One, we think that this continues to reinforce that stem cell transplant should be considered a therapeutic option at centers of expertise for patients with medically refractory Crohn's disease. We also demonstrate, similar to previous studies from other groups, that intestinal macrophages may have a central role in Crohn's disease biology, and it may be that how macrophages coordinate tissue healing is important specifically in our patients with very refractory Crohn's disease that don't respond to traditional immunotherapies. And finally, we demonstrated that stem cell transplant may function as a myeloid-directed cellular therapy, and that we may need functionally intact stem cells to drive this therapy, and that future studies need to look at the potential effect of Crohn's disease on the stem cell niche in the intestine. Thank you very much.